It's really an honor. And I think it's going to be an interesting discussion as we have real, very well-known experts here. And I'm really interested in your opinions on our cases. So the idea is that we go through the cases and that we have some questions prepared on those cases. But of course, the idea of this new format is that we really start to have a discussion on some details. And just some weeks ago, this new ENSIAN classification, the hashtag ENSIAN classification, has been accepted for publication and is now available in PubMed. And I have the pleasure to introduce Jörg Keckstein from Austria to present this new hashtag ENSIAN classification and give us a short summary of how to use it. Jörg, I know it's difficult to do it in a short way, but we only have 60 minutes, so we want to try to just use it. And I would be happy if you can introduce and explain it to us. Is Jörg already here?
I think he's not. Hello, everybody.
I don't see him on the list. Nope.
Okay, so maybe we, I will just check my phone if he tries to enter and cannot enter. Alin, he says that the host is not letting him in.
I accepted everybody. Maybe he's on the not on the right Zoom meeting. Can you ask him to type live.endometriosis.com?
Yes, I send this to him. Okay. Maybe you can start, Alin, you can start to explain a bit and I will just call him, okay?
Okay. So the hashtag ENSIAN classification will classify the endometriosis lesions on the peritoneum, on the ovary, on the tubes, plus the old ENSIAN classification, the ABC, the rectovaginal space, the vagina, and then the pelvic sidewall, including the sacrouterine ligaments, the cardinal ligaments. Then the C compartment are going to be the lesions on the rectum. And the lesions in the uterus are going to be classified as FA, the adenomyosis. The lesions on the bladder are going to be FB, just like before. FI for the bowel endometriosis lesions, and FU for the lesions that are infiltrating the ureter, not only doing a compression on it. And the FO from the old classification is going to be F, and in the brackets we can write the lesions wherever they're localized. For example, diaphragm, lungs, or nerves. So the new sections of the hashtag classifications are actually the P, the O, and the T. And for peritoneum, they're going to be 3 situations, P1, P2, P3, depending on the sum of the dimensions of the lesions that are localized on the peritoneum. O is going to be for the ovary. And we're going to have, for example, O1/2 if we're going to have an endometriosis cyst under 3 centimeters on the left ovary, and for example, 5 centimeters on the right ovary. Then the T section is going to present the situations of the tubes. If there are any adhesions, the motility of the tubes, and the patency test. Just like in the O section, we're going to have T left/right, depending on the adhesions of the tubes. So T1 is going to stand for the adhesions between the tube and the pelvic sidewall. T2 are going to represent adhesions between the tube or ovary and the pelvic sidewall and uterus. And T3 is going to be the situation where the tube and the ovary would be attached also to the bowel or to the sacrouterine ligament. Take a look and see if prosecution time is here. Nope, not yet.
Yeah, I called him and he seems to have some trouble with the internet connection.
Oh.
So maybe he will join us later.
Okay, then maybe we can come back later to the hashtag
Yes.
NCN classification and get a full description from him.
Okay, so Alin, I think this would be the moment to start the first case, and you're going to present the case from the clinic in Frankfurt, right?
Yes.
Okay.
So the first case is a case of a 33 years old patient, 3 gravida, 2 para, with dysmenorrhea with a score of 7 from 10 on the visual analogous scale, and the dysuria 4 from 10. From the medical history, the patient had 4 laparoscopic endometriosis excisions surgeries. When she came to our outpatient clinic, she didn't have any surgical reports, so I didn't know exactly what kind of surgery was performed. She had 2 vaginal births. Previous ART, she had 2 IVFs. At the moment she came to us, she mentioned that the family planning was complete and she doesn't wish to have any other pregnancies. And otherwise, the patient was healthy, no relevant secondary diagnosis. She started with a combined oral contraceptive with Dianogest for more than 11 months, which she didn't tolerate very well, having spotting and also more than 5 to 6 days per month with abdominal pain. The clinical gynecological examinations, the speculum rectovaginal examination and bimanual examination showed normal findings. And the first questions for our speakers would be, what imaging diagnostic would you propose in this case?
Shaheen, maybe you can give us an idea of your strategy in those cases, as you are
Yes.
a specialist of bladder and ureter endometriosis.
Yeah. Well, answering this question, we always start with an ultrasound scan as routine. I do my own ultrasound scans in clinic, and I think that would be a good start. That should include a kidney ultrasound scan as well to rule out hydronephrosis, and also to do the ultrasound scan with the bladder empty and then bladder full to look for any bladder endometriotic nodules.
Do you always perform a kidney ultrasound in all endometriosis patients?
Only in those where we suspect a deep infiltrative endometriosis, so always in people with endometriomas, for example, or those who also have urinary tract symptoms.
Thank you, Alin. Then let's have a look on the ultrasound images.
Okay, so in this case, I performed the transvaginal ultrasound and the renal ultrasound. The TVS showed a normal uterus without any signs of adenomyosis. The right ovary showed normal findings. The left ovary and the left tube were attached to the left pelvic sidewall. On the bladder dome, I saw in the first place a nodule 1.2 per 1.5 centimeters. This is transverse section through the bladder, showing the nodule. Then I saw another nodule a little bit to the lateral from the first one, almost the same size, 1.1 per 0.9 centimeters. And this is a section showing both nodules in the bladder dome infiltrating the bladder wall. I think someone is, okay. This is a video from the, someone is drawing on the screen. It's not me. I need to see how I can take this away. Not
There is a ghost.
There is a ghost, so clear all drawings. Okay, so if someone is drawing on the screen, please stop it. So this is the video from the ultrasound showing the two nodules, showing the right urethra. So this shows that the lesions are far away from the urethra. Then the renal ultrasound excluded hydronephrosis. And here comes the next question. Would you ask for any additional diagnostic exams?
Who would go for an MRI in these cases?
We would always do it, I have to say. But of course, it depends on your access to MRI. But we have free access, and we will any suspected deep endometriosis, we would always do the MRI. But I think it's quite individual. Yeah.
Yeah, I agree. An MRI in a case like this would be helpful. I think depending on what else we'll find, but we have most of the information we need already, but an MRI wouldn't be a bad idea.
If you have the result of the MRI, you just trust in the radiologist's view, or there's some kind of board that gives you the opportunity to watch and screen the MRI images with the radiologist and have an idea together.
Yeah.
Depends on the radiologist.
Yes, I mean, we are very lucky. I work with a radiologist who is very passionate, and she normally texts me on WhatsApp and says, do you have 5 minutes? I want to go through these images with you. And then we will discuss it at our multidisciplinary team meeting as well. So we'll look at the images all together.
That's the same with us. We have a team meeting, or an endometriosis team meets with the MRI radiologist once a week. All examinations are looked through there by clinicians and the radiologist. And he happens to be both the gynecologist and the radiologist. That's quite special. So I think the really dangerous ones are the false negatives. That's false positive. It's not that serious, because then you will go in there and you'll look at it. But the false negatives, if you then don't do anything to the patient, that's the serious cases. But that's very, very rare.
Arlene, how did you do it?
Well, we didn't perform any MRI, and I have to tell you that we perform MRIs quite rare in our clinic. We have a great sensitivity and specificity for the endometriosis diagnosis. And I think the only situations when we ask for an MRI is whenever we have any suspicion of endometriosis of the sacral roots.
Arlene, I have a question. The ultrasound, did you do the ultrasound?
Yes.
Okay. And Shaheen, are you doing the ultrasound in your center?
Yes. I do the ultrasound scans, although I don't know how. I'm not as good as many of my colleagues who do only endometriosis ultrasound scan, but I'm getting there. The problem is, at least in 5 or 6 cases in the last year, the MRI has shown us things that an ultrasound scan wouldn't have shown us, like, you know, higher nodules, and also, you know, other issues with the appendix, with the upper abdomen. And it's very individualized. I think it depends on the center. It's very operator dependent. And unless you are yourself very confident in doing it, I think, you know, the combination of two, if we can do it, is the right answer. But it depends on the patient, of course.
Yeah, I think it's a very interesting detail, because some surgeons do ultrasound, others don't. Others just trust in MRI that is done by a radiologist. And I think it depends on the workflow. And if it's good and you have good result, then there are different ways to a good result.
That's true.
Arlene, now please present the hashtag ancien classification in this case.
So our hashtag ancien diagnosis after performing the ultrasound was T1/0FB. So adhesions of the left tube between the left tube and the ovary and the left side wall, and endometriosis nodules in the bladder. So this would be our pre-surgical hashtag ancien diagnosis.
Okay. Which are the treatment options? Axel, what do you think? What would be the right way, in your opinion?
Well, if we're now suggesting that these are only the nodules we find in this patient, we would make surgery. Because although we feel very much for, the principle is that what can be controlled by the pill or such things should not be operated. But our experience with medical treatment of bladder deep endometriosis is bad. So we would always go to surgery, also because results are excellent for bladder endometriosis. So that would be our approach, I think.
Elvira, do you agree with this approach?
Yes, I totally agree, because surgery in deep endometriosis in bladder or in bowel endometriosis, I think it's a good option, especially if the patient has symptoms, and she has symptoms, and medical treatment. I don't believe it works in deep endometriosis. Maybe decrease a little bit from symptoms, but doesn't treat deep endometriosis. The disease progress, doesn't matter if you give medical treatment or not, especially in bowel, bladder, and in parametrial endometriosis.
Okay, thank you. Arlene, please show us the treatment approach, and I think there will be a video.
Yes, 2 videos. So the preferred treatment was the insertion of bilateral DJs stents, cystoscopy, and the laparoscopic excision of the endometriosis nodules. The first video is the cystoscopy with the insertion of the bilateral DJs. Here we can see one of the nodules protruding in the bladder. There were no problems inserting the DJs on the left side and on the right side. And I think there is another view with the two nodules, the typical image of bladder nodules, blue protruding in the bladder. The next video is the laparoscopy, showing superficial endometriosis nodules, endometriosis on the ovary. The left ovary and the left tube is attached to the pelvic sidewall, a small ovary, probably from the previous surgery. Then there are the endometriosis nodules that we saw in ultrasound, plus another endometriosis nodule close to the round ligament. So we perform systematically the sigma desiolysis. We identified the ureter. Here we had to do an ureterolysis because the left ovary was attached to the pelvic sidewall. And then we excised a small lesion on the sacrouterine ligaments. Then there were the superficial endometriosis lesions on the left ovary that we also excised. And then we performed an ovariopexy so that we can work on the pelvic sidewall. On the right pelvic sidewall was another lesion. So we opened the peritoneum. We performed the hydrodissection. And then we performed the peritonectomy, and we took extensively the peritoneum out from the right sidewall. And then there was also another lesion on the right uterosacral ligament. There was also another lesion in the pararectal space, superficial, that we also excised.
Aline, would you always insert double J in cases of bladder endometriosis?
Well, not always, but in this case, given the fact that the patient had bladder endometriosis and she had 4 previous surgeries, and I didn't have any clue what was performed, I think this was the safe way for me, at least. So this is one of the endometriosis nodules that we saw in ultrasound. That I first excised, and this was the second. Then I tried to mobilize the peritoneum on the bladder so that I don't have any tension when I would suture the bladder after opening it. This was the second nodule. I think somewhere was another rest.
Shaheen, one question. Would you fill the bladder during surgery?
Yes, I would fill, not completely fill so that it's completely distended, but half fill the bladder with normal saline. Helps usually quite a lot. And I normally, as Alan is doing, I would open the bladder soon in the process of the operation so that I can see the other end of the nodule, because the last thing you want is to leave something behind here. I've seen one patient with recurrent bladder endometriosis, which wasn't recurrent, it was left over, and you really don't want that.
I sutured the bladder in 3 layers. First, a double layer continuous suture with Vicryl 2.0. And then it was another additional layer with PDS 2.0. And after the 2 layers, I did the test to see if the bladder has any leakage. Everything was okay.
Aline, for how many days usually do you leave the Foley catheter?
Well, depending on how extensive was the surgery, we do it for 10 to 15 days in the clinic.
Other opinions from our experts?
10 days,
Yeah, we
I
do the
think.
same.
We say 7 days.
Okay. And then do you do a cystogram before taking the catheter out?
Yes, we send the patients to the urologist. They do the retrograde cystogram, and if everything is okay, they take it out.
Yeah, and you may not know the answer to this, but do they also do a voiding cystogram?
I don't think so.
Okay, because
No.
I mean that's a minor point, but I had a patient with a very large bladder nodule not that long ago, maybe 3 months ago, and when we finished, it was completely watertight and it was very good seal. But when she went for cystogram 10 days after the operation, the report said there is a leak. And we said, okay, let's leave it for another week. And then second time, there is a leak. And then I picked up the phone and talked to the radiologist. And what he was doing a voiding cystogram as well. And that's not necessary. When the pressure in the bladder goes really high, when the patient is voiding, you may have a few drops of urine coming out. So yeah, that was something to learn, that voiding cystogram is not necessary.
Yeah, they don't do it, at least in our clinic.
Yeah.
So the hashtag NCN classification after the surgery was P2, T1/0, B1/1, and FB. I think Professor Keckstein is here, and I think he can comment on that if you saw the video.
Hello. Yes, I will make a comment. Thank you very much. Sorry, I'm delayed. I had a problem with the internet, but I followed this case completely. Aline, very nice presentation, and there's nothing to say, or not. We have a lot to say, but you managed the brand new hashtag NCN very well, and I absolutely agree with your classification. And you see that there is a not completely the same preoperative assessment, but this is also shows that probably, let's say, in the hand from Katharina Exarchustus, she may have seen some of the lesions in the B compartment, but this is what we probably use in this classification are now. We have to be very eager to have the same classification pre and post-operatively. This is now a kind of quality control, and it makes you also the radiologist. You can go to the radiologist and can say, "Oh, you have missed this and that. Please look at your picture again." And this could start a special training or learning process for all of us, not the radiologists, also for me and for other surgeons. I think this is a kind of communication. Now we have a language where we can communicate and ask you, why haven't you seen the B compartment, for example? And so, Aline, I totally agree, and nothing to add. I mean, you have seen.
May I ask a question, Jo?
Please.
I don't know if you saw the video. Hello, by the way. Nice talking to you. The O on the right, there were some lesions on the ovary. Would that be counted somehow?
Yes, this is a good question. If it's more than 5 millimeters, probably you should then classify it as a deep endometriosis in the ovary. And I was not sure if it was visible in the ultrasound. This dimension seems less than 5 millimeters. I'm not sure, because when you see the diameter of the instrument, this is 5 millimeter, and it is a little cyst. I mean, you can say it's a 0 0.001.
Okay.
You're right, but if it's superficially, it's peritoneal lesion, and if it infiltrates into the ovary, into the depth of the ovary, then you have to classify O. You are correct.
And if there is superficial lesions on the ovary, would that be counted as peritoneal or
Peritoneum.
separately?
Yes, peritoneum.
Okay.
Thank you, Jörg. There's a question from the audience in the chat regarding the double J stent. Arlene, when did you take them out? At the end of the surgery?
No, we kept them for 6 weeks, and then the patient went to the urologist, and they took the DJs out.
Maybe if you know, you were asking if we were doing anything differently, I would say that first of all, there probably wasn't any need for the double J on the other side. You know, maybe on the right side where you've seen with your ultrasound, yes, but that just adds to the morbidity. And then I would probably have taken it out at the end of the procedure. You haven't done anything to the ureters to worry about, but.
I can make a short comment on that, if I can. The thing is, you have placed the double J, but I have seen in some other places you only have to introduce the blue guides, both, and you leave it out through the urethra, and you leave it as long as you operate, and then you draw it out. So you have not to put in the stent and so on. You just put 2 guides, left and right, the blue ones, and you leave it as long as you operate, and at the end you withdraw it. It's easier, faster, and no, you don't have to place a whole double G into the kidney. You only need the guide within the few centimeters above the bladder. That's enough. And this makes everything much easier.
Another option would be the elimination by ICG. What do you think about that possibility?
Yeah, then you don't know. I mean, you can do it, but in fact, sometimes you need the tactile feedback of the tissue. I mean, ICG is perfect, but you need a lot of equipment only for that, and that's probably the future. But double G also gives you an idea where it goes, and the tactile feedback during surgery can be helpful. But I have no experience with the ICG in this indication. I cannot say anything about it.
Yeah, maybe in one of the next sessions we can show some videos on ICG trans-elimination of the ureter, which is a very nice technique. The last question in this case would be, what would be your recommendation for the post-surgical treatment? Would you go for some hormonal treatment, Axel, or would you just say, okay, this is fine because it was a deep endo and we did the surgery, so now everything is okay?
Well, I would say that it was not just deep endo. So our approach is that if you're not going to get pregnant, then as a minimum, the Gestogen IUD and or the mini pill. If you are age more than 35 years, less than 35, of course, then you can also use the pill. But we do it with almost all patients. If the patient doesn't want to take it, that's something else. Then of course it's a choice. But we do think that we have less pain recurrences.
Elvira, what would be your approach after surgery?
Taking into account that this patient has already 2 children, I try to say that I only follow the patient, and I don't want to prescribe medical treatment. Maybe if she wants for contraception, intrauterine device with progesterone, but not more. I think to follow up
Mm-hmm.
the patient, it's enough. I'm curious, at the preview for operation, there was no deep endometriosis in the bladder? Maybe
Yeah, there was.
I didn't have I didn't have any surgical reports from the previous surgeries, so I had no clue what the patient had.
Because I don't really believe that this bladder endometriosis appear after all this.
He's been there for years.
Yes, but this is a frequent problem, and this is because of the difficulties in the diagnostic approach
Yes,
that we discussed earlier tonight. And an MRI would be helpful in those cases when there's nobody in the unit really able to do a good transvaginal ultrasound of the bladder. But the leading symptom of the patient guides you to the bladder. So then by ultrasound, usually you can find it quite easily, even if it's hidden in the retroperitoneum in the laparoscopic view. But as we have seen in the beginning, the ultrasound has been performed with a medium filled bladder too, and this is a very important point.
Harald, you have to unmute yourself.
The microphone.
No, okay.
Okay.
Now it's working.
Sorry. Yes, we have seen the ultrasound with a filled bladder, and this is very important as this gives us the opportunity to really see the infiltration of the wall, even if it's a small nodule. And usually the transvaginal ultrasound is being performed with empty bladder. So sometimes then it can happen that you just overlook these small nodules.
Yeah.
Shaheen, would you give a...
Yeah, just wanted to add one thing that I would be strongly recommending post-operative, if possible, combined contraceptives in view of that right-sided small endometrioma. I think for that we have very good evidence to show that it does reduce the chances of endometrioma regrowth and formation. If that wasn't there, I would be sort of 50-50 depending on what the patient wants. But in this case, I think I would be strongly recommending.
That's correct.
Okay, thank you so much. So I think we go to the second case.
Just one more thing. In this case, I recommended the patient the mini pills and also rehabilitation in an endometriosis center. And that's a standard recommendation in our clinic for all the patients having deep infiltrating endometriosis.
I agree.
Thank you, Alim. Very interesting case. And thanks for the discussion. The second case is completely different. And Andrea Noppev from Böblingen will explain this case to us. Andrea.
So hello, everybody. I'm pleased to offer you the second case today. The 18-year-old patient, 0 gravida, with severe dysmenorrhea, with nausea, vomiting, and also a heavy dizziness. She has to lie in bed for 2 to 3 days per month. She's also suffering from dyspareunia, dysgeusia, and dyschezia, and sometimes diarrhea. So in case of medical history, there were no previous surgery, no relevant secondary diagnosis, and so far no medication. So the clinical gynecological examination was also normal. The speculum examination showed a portio macroscopically normal, fornix posterior without infiltration, and also the bimanual examination was an intratus narrow, cervix delicate, and uterus retroverted, mobile, and alexia bearing both sides free, posterior soft fornix. So what imaging diagnostic would you propose in this case?
I think it's better to start with ultrasound. It's very easy to do and it's very cheap.
We would do that too, yes, of course.
Yeah, that's providing it is acceptable to the patient. transvaginal ultrasound scan. Yeah.
Yeah, of course.
Okay, Andrea, then let's have a look.
So we did the ultrasound. The transvaginal ultrasound shows a retroflected uterus. There was no signs of adenomyosis. And also the ovaries were both sized with normal findings. And we did a renal ultrasound also with normal findings without hydronephrosis. Would you ask for any additional diagnostic exams in this case?
I don't. We don't in our center. That would be enough.
Well, we have to say that if you have dyschezia, then we always do the MRI. Always. But it's dyschezia is not a very specific symptom, but we cannot bear to have a patient passing our hands without detecting it. She should have a high nodule, which we cannot see with vaginal ultrasound. So, and we have this free access. So we would do it.
Sorry, may I ask you, the dysmenorrhea is 8 from 10. Is that right?
Dysmenorrhea was severe, yeah, so 9 from 10, yes.
In this area also, okay.
Yes.
Okay.
May I ask you something? Did you see the patient immediately after mens to see if she has, I don't know, a little bit more fluid, blood in the pelvis with the ultrasound before sending her to the MRI?
At this time, she was in the outpatient department. She had her meds, so it was a period at this time. So the patient wants conservative diagnostic to be exhausted and asked for hormone status and MRI diagnostic.
So
what do you think about the patient's wish?
What do you mean hormone status, as in measuring her hormones?
Yes, for example.
We don't do that. We don't find that useful at all.
You don't even, no.
Yeah. I think that the case you're presenting, even if something surprising comes out of this, which is possible, I would manage based on the clinical pictures, and examination is probably the most important one here. And an experienced endometriosis surgeon examining a patient like this will give a lot of information about what the next step should be.
That's of course true. Of course it is, but it depends on local tradition and perspectives, I think. But of course,
that's true.
Experienced surgeon is a very, very good tool to have in such cases. Yes.
So we did the same. There were no other diagnostics. This was an endometriosis typical complaints. Clinical and sonographically, no evidence for deep infiltrating endometriosis so far.
Okay.
So which are the treatment options?
Well, as always,
only medical treatment. Was it only medical? No surgery?
Do you all agree? Medical treatment and no surgery?
No, I wouldn't say so. I just asked if the patient wanted conservative treatment. Was that true? So she didn't want to have surgery, or?
Can you go to the next slide, Aline, please? So we offer the woman a laparoscopic examination because of the symptoms, and also medical treatment to take an amenorrhea with combined oral contraceptives or insertion of the progesterone IUD.
Yeah, that's true, yes.
That's reasonable.
In this, may I comment? in this very young patient with this kind of symptoms, with not clinical or ultrasound sign of endometriosis, I usually try to manage with homeopathic treatment, yoga, and I ask them if these symptoms are related with the amount of menstrual cycle, because sometimes when they have few blood during the mens, they have more clinical symptomatology, more heavy clinical symptomatology. And sometimes with yoga, with sports, with anti-inflammatory homeopathic treatment, sometimes works. In other cases, I used to try with therapeutic estroprogestative pills, but first try with homeopathic treatment.
Do you mean, Elvira, did I hear correctly? Did you say homeopathic treatment, as in water?
Curcuma or kudsurot.
Yeah, water. Yeah. I feel very strongly about
you know,
that.
sometimes work.
Yeah, of course, water works.
I have to say something. Homeopathic is completely something different to curcuma. Homeopathic is a special treatment with where you have to look for a special agent which works. And from my feeling, homeopathic doesn't work in endometriosis. I'm sorry to say that, but my wife, she's gynecologist and she does also homeopathy, but she has little success with homeopathy. It is different to alternative treatment.
Yes, alternative treatment.
Yoga and something else. This is completely different. Homeopathic is a very specific treatment, and we should distinguish between these. Otherwise, the patient, they put everything in one pot and they say, I did something homeopathic. But in fact, if we want to respect these different type of treatment, which we sometimes need with our patients, they have to look for osteopathy or for TCM. Then you have to name it exactly what they want to have to do. That's my experience. And I think this patient, which Andrea now presented, they have to look for something that, and they have to get more education on her pain management.
Thank you, Jörg. I would like to ask another question on this case. When would you go for initial laparoscopy? If the patient would be 25 years old, or she would have a wish of pregnancy and cannot get pregnant, what would be a difference? This is always the same question. We start too early with the laparoscopy, or we have a delay and start too late. When is the right moment? What is your opinion?
Well, it depends on the age, exactly. And when you follow the patient and you have the impression that the pain is getting worse and worse, then I give the indication for laparoscopy. But before I do that, I want to know more about it. Is there any hormonal correlation? And if you give the contraceptive pill continuously and she will continue to have pain, then it's much more likely that it doesn't come from endometriosis. And then this I explained to the patient that I said, well, first of all, let's have a hormonal diagnostic treatment. That means you have not to take it for years, just take it for 3-4 months and then have a look. And then you get an impression, is there any correlation or not? In the meantime, you have to do something else. What Elvira said, they have to do something which is not the typical hormonal treatment. And if the patient is very young and you see that she is missing the school or she's cannot work, then I believe sometimes we should look inside and to exclude some superficial peritoneal lesion, which is not visible in ultrasound. And then I would do that, because there are cases with disseminated lesions all over the peritoneum, which are not visible during ultrasound or MRI. For that reason, we should also be aware that if the patient, let's say 5 years later, she gets a laparoscopy, and then they say, why they didn't look in? So, but I don't do it immediately, never.
Yeah.
But Jörg, nice to see you.
Nice, yes.
Yeah. Doesn't this initial approach depend on whether you can keep her amenorrhoic? Because if you cannot do that, then pain goes on actually, because they are so sensitized, and even small bleeding they hurt. That's since they have this dense innervation of the endometrium and so on. So this approach is mainly for those who can be kept without bleeding for 3 or 4 months, isn't it? I think if you cannot keep them there, do you use then? We often use the combination of the estrogen IUD and the pill, and that often works in our hands.
The combination of what?
Of the Kylina, as it's called, the small
Okay.
estrogen IUD and the pill, and that works very often, especially in the young ones.
Okay.
That's a good approach if you don't want to make a laparoscopy. And I agree that you would be hesitant to make a laparoscopy a girl of 18 years.
If I may say something to this, particularly with younger girls, I think what I have found is, like most other situations, practicing evidence-based medicine means putting the patient in the middle of all of this and really explore what her wishes and conceptions of the pain is, as Jörg said correctly. There is never, in endometriosis, there are many different scenarios where you are sure that surgery is the right thing to do. But in these situations, it really is not possible to have a guideline or a flow chart to say if the age is this and it doesn't respond to that. So in some young girls, it's useful for them to know for sure whether they have endometriosis or not, particularly now with social media being so strong. It's very damaging to them psychologically if they have in their mind that I'm an endometriosis sufferer and I'm not being offered a laparoscopy or a treatment. Sometimes in some of these girls, it's much more useful to give them the answer, you do or you do not have endometriosis, and let them, carry on with their treatment. But every case is different. I completely agree. Every person.
Shaheen, I absolutely agree, but there is one problem, one single problem. How many patients, you personally, do you scope and you don't find absolutely nothing? I'm sure you're able to find in 90% a little endometriotic lesion.
Yes, that's true.
And this is our problem. If we once did the biopsy of this little lesion, the patient is on that track.
Yeah.
What do you say about that?
Yeah, well, it's a difficult one because we really haven't proven the clinical relation between that kind of little lesions and pain. I will turn the question around and I will say to you that in 5 years' time, as you mentioned, the patient will end up, a patient at 18 with chronic pain that stays in bed for 3 days is definitely going to have a laparoscopy in the next few years. And some clever guy is going to find the lesion and say, Dr. Khazali, Dr. Keckstein misdiagnosed you or ignored your diagnosis.
Right.
And I think that is also something that we need to keep in mind, that with any intervention, we are doing some harm as well as some good. And sometimes that label, as you correctly say, may be harmful more than helpful. Who knows? I don't know the answer to that.
So I'm very curious what happens with the patient in Böblingen.
Finally, the patient opted for combined oral contraceptives, and so far she had a significant reduction of her symptoms. So,
yeah, that's good
I
result.
would like to ask you one more question on this case. If you do an MRI and it's completely negative, it still does not mean that there is not a small peritoneal endometriosis. And then the treatment is hormonal, let's say for 7 or 8 years. And then after planning pregnancy, the patient comes back with infertility and pain. Would you say these 7 or 8 years under hormonal treatment are problematic and there should be a follow-up in between, or how can we avoid these cases? Do these cases exist or not? I mean, I have the impression that we have these cases.
Just a short comment. If you have done an MRI, you have to know who is doing the diagnosis there. This is the most important thing. If the radiologist doesn't know endometriosis, the MRIs are worthless. And this is a big problem.
Yes, but Jörg, we discussed that before, and Axel told us that they are doing MRI as a standard procedure, especially in.
But they have specialists.
Yes, they have a specialized team and a board,
yes.
which
of
is
course.
discussing
Then,
the case.
no problem.
But our experience is that MRI does not tell you anything about peritoneal endometriosis. It shows you nodules and it shows you the endometriomas, but it does not tell you anything about peritoneal endometriosis. That's one thing. Next thing is the question Harald raised, which is very important, whether this treatment for maybe 5, 6, 7 years with an oral contraceptive does it hurt, or how is it? And I think that we have no evidence if it helps the patients to have an early diagnosis or if it's better to wait, actually. So I know of no papers on this issue. And we also don't know actually whether surgery for peritoneal endometriosis actually helps the patient. No one ever did this. And the early studies by Chris Sutton and by Ray Gary, they told us nothing about this group. Actually, the results of Chris Sutton showed very limited effects in stage 1 and 2 endometriosis. So that's a very important question, and it is still unanswered.
And I think, Harald, you ask a very good question, and the more our societies become litigious and we become like Americans, the more patients we are going to have that come back to us and say, why didn't you remove my endometriosis? What I do, which I found helpful in most cases, I don't tell the patient you don't have endometriosis. I say there is a 10% chance that you have endometriosis. There is a 20% chance, depending on the clinical findings. But we are deciding to manage it conservatively because 1, 2, 3, 4, and I discuss with her what the implication of this is. And in particular, I tell her what I don't know. I tell her I really don't know what the implication of not removing a superficial endometriosis at your age is. Nobody knows. But I do know that surgery also comes with risks and problems. I may be causing adhesions that equally may be causing problems. And it's always, there are patients who will say, no, 10% is too high a chance for me to accept, and I don't like the idea of having endometriosis in my body. There will be patients who think differently. Ultimately, it is the patient who decides. We need to remember that.
And there is another aspect to this. We know that even patients with only primary dysmenorrhea are what's called sensitized, which means that they have an altered brain handling of pain and altered spinal handling of pain. and they have actually an enhanced pain response in all these areas as compared to women without pain. So these patients run a risk of more severe sensitization if we make the surgery. And we haven't included any patients yet, but we are actually trying to make a protocol, a randomized controlled placebo double-blind controlled study on surgery for peritoneal endometriosis. We'll see if we can get patients into it, because the approach is that patients are randomized during surgery and they don't know for the next half year. They don't, and the doctor doesn't know, those doctors who make the follow-up, whether they had the surgery or not. But it's difficult to make patients accept it. But we try to do it because it's really a black spot. It's an unknown area in our subspecialty.
Okay, Andreas, thank you for this very interesting case. It seems a simple case because it's a non-surgical case and there's no deep endo, but it's a difficult case, and we all have a lot of these patients. And that's maybe when endometriosis starts. I really feel that it's very difficult. For me, it's easier to have a bladder nodule and I can just take it out and solve the problem. So I think the discussion was really very interesting. I told you that we prepared 4 cases, but we discussed a lot on 2 cases, and now we are running out of time. So if you think this was interesting and if you would like to see more of case discussions, we invite you to come back to EEL Cases under discussion in March 30th. I think the missing 2 cases from today, it would be really nice to continue, but for today it's enough. And next time we are going to talk about another deep infiltrating case and a rare case. And Ali, maybe you can show the slide with the invitation for the next cases under discussion round.
Harald, why don't we discuss the other 2 cases in the we have a Facebook group, don't we? In some kind of forum, we can always have some sort of online discussion. I'm sure the young team have spent some time preparing them. It would be a shame to let it go to waste.
Yeah, I mean, if we could do one more case today, for example, if you agree, I don't know, but I think we are all spending a lot of time here now, and I love to discuss with you, but I was afraid to ask you to continue. So I think we just skip the 2 left cases to the next session. So
okay,
that's what we expected. We prepared 4 cases, a 5th case in case that we are too fast, but now we discussed a lot on 2 cases, and I think that's fine because that's the idea of this format, that we discuss the details. I would like to thank you for your expert opinions, for your comments, and for the discussion. It really has been a pleasure to see you and to discuss with you. Thank you a lot. I also would like to thank the audience of 70 people from different countries and continents. Thank you so much. We're going to try to answer some chat questions afterwards. And at this moment, I would like to invite you to the next EEL event, which will take place the 16th of February by Gernot Hudelist, the 2nd webinar of the webinar series 2021. He's going to talk about complications of deep endosurgery. I think this will be very interesting too. And as you know, in our webinars, we have 30-40 minutes of presentation and then also a discussion at the end. And as I said before, at the 30th of March, we are going to have the 2nd cases under discussion session with another 3 experts, Michel Nisolle from Belgium, James English from the Netherlands, and Attila Bokor from Hungary. Thank you so much for joining us tonight. Let's stay in contact, stay safe, everybody. See you soon. Thanks to the young.
Thank you.
Thank you very much. Very nice.
Thank you.
Thank you very
Bye-bye.
much. Good.
Good to see you all.
Thank you.
See you.